Bill, just want to thank you so much for being with us today.
Good to talk to you.
Back in 2015, you gave a TED Talk that was unfortunately pretty prophetic. You said that it was not missiles but microbes that we had to worry about. You said the world community wasn't prepared for another pandemic like we saw back in 1918 with the Spanish flu. When did you first start to think that COVID-19 might be the epidemic that you'd been worried about?
Well, anytime you get a human-to-human transmissible respiratory virus, it could be the one. And so you're always watching whether it's a variant of the flu or any other respiratory virus, because once it's transmissible at a certain level, because of all the travel we do, it's likely to go completely global. And then the only thing that can help you out is if it's not very fatal. But here with coronavirus, it's quite fatal and quite transmissible. So it's the nightmare that we've been talking about for a long time. And sadly, although a few things like this coalition for vaccines, CEPI, were done after 2015, a very small percentage what we should have done, where we would have diagnostics very quickly, drugs very quickly, and a vaccine far more rapidly.
Why don't you walk us around the globe right now? We're hearing things that maybe things are improving in China, maybe they're coming out the other side of things, although there is some talk of potentially a second wave of transmissions that's taking place. With all the information that you're getting right now, what's the best view you have of what's happening in China, in Europe, here in the United States, and other places?
Well, China took the situation in Wuhan, which was quite dramatic, and by extreme interventions in terms of reducing movement, they were able to crush that epidemic. Those hospitals are gone. Look at the commerce. Stores are open now in China and nowhere else, whereas before it was the opposite. And so it's a real thing that they took a significant number of cases, not only flattened it, but brought it down to very small levels. Now, as they open up, there will be slight rebounds, and it's very valuable for them to share where that's happening, because all the countries that have substantial epidemics now have to think, okay, once you get down the absolute level, before having a vaccine, what kind of activities should we re-engage in? Probably manufacturing we can do, probably construction we can do. Hopefully, because of the number of young people involved, we can do education. But we're going to have this intermediate period of opening up, and it won't be normal until we get an amazing vaccine to the entire world.
You talk about these intermediate steps. The president tweeted earlier today, just a few hours ago, that he wants to get us reopened sooner rather than later. What's the timeline that you kind of have in mind of when we might be able to get back to business, when we might be able to open the economy, when things start heading more towards a path towards normal?
Well, unfortunately, the U.S. isn't uniformly shut down. And so what you're going to see is lots of exponential increase in various communities. Also, even though our testing numbers are going up, the number of days to get a response, it should be under 24 hours. And even for priority things, it's taking longer than that. And so that, there's no system of prioritization. That still needs to be fixed. If we get our act together countrywide, and if the compliance is very high, and that testing, including some innovations like the self-swab that our foundation has driven, if those get into place, by early June, we'll be looking at some type of opening up. Now, the definition of that is what we need to be working on now, studying what's been done in South Korea, what's being done in China, and various parts of Europe, including Sweden, who, at least as yet, has chosen not to go for a full shutdown like many other countries.
Where do you think things stand in America? I mean, it's different in different pockets, as you pointed out. In Seattle, you guys were kind of on the forefront of it. Here in the New York area, we're looking towards that peak right now, but the number of cases and how quickly they've multiplied has been kind of stunning. Where do we stand around the country as you hear about outbreaks in other places like New Orleans, Chicago, and beyond?
Yeah, our partner, IHME, if you go to healthdata.org, you can find they take localities around the U.S. and look at their prediction for when the cases will peak, and therefore projections on how much ICU capacity and ventilators will be needed. And they assume a pretty good compliance. You know, what you see is that a lot of counties have this exponential growth. And wherever you have cases and people still mixing around, that is what's going to happen. And so it's great that Seattle, the doubling rate is down pretty dramatically here. And we're the first community with the thing called the Seattle Coronavirus Assessment Network. We're doing the first surveillance to see what cases were missed, what's the age structure, and understanding that transmission. And the data back from that will be a key input to designing those opening up policies, what should be done there. So Seattle is leading in some ways. Sadly, we had the first imported case, and a previous effort, the Seattle Flu Network that I ran, actually was the first to see community spread because we were doing testing even when you weren't supposed to test people who hadn't actually gone outside the country. So yes, some places are near their peak, but just because things start to come down, that's not the time for opening up. The absolute level has to be very, very low, and you have to have a new testing system that prioritizes seeing any new cases and doing contact tracing, quarantine enforcement. That the Asian countries are great examples of doing that in a very strong national level approach.
Bill, we have guests who come on our program pretty frequently and say that maybe the cure is worse than the disease. What's your response to that?
Well, I think it's very difficult when you have a lot of people dying of a disease that even if the government says, okay, let's keep the GDP reduction down, the behavior of people in terms of wanting to travel or go to events or even go to a restaurant, it's been utterly changed by the concerns about this disease. And so until we can say to people that we're tracking this thing so well that actually going out to your job, to a car factory, to a construction site, that those are safe enough that we feel confident you can do those things. Until we get there, which we're absolutely not, no one should think the government can wave a wand and all of a sudden, the economy is anything like it was before this happened. That awaits either a miracle therapeutic that has an over 95% cure rate or broad usage of the vaccine. And so, we've had a demand side shock and a supply side shock. And that demand side piece is both mediated by fear of infection and by the overall wealth effects of many people losing their jobs, and entire industries will be operating at a far lower level than in a normal economy.
Let's talk a little bit about what the Gates Foundation is doing. First of all, how much information you're getting, where you're getting that information, because I get the feeling you probably know more than just about any place else. You've agreed that you're going to spend more than $100 million on this. Where is that money being spent? What do you think is most hopeful in what might help us in this situation?
Well, the areas that we have the deepest expertise in is how you do testing, how you find drugs that will save lives, and how you get a vaccine that making 7 billion of those is going to be an incredible challenge. And so, we've taken our normal work, on polio eradication or some of our HIV, TB work, and we've had to redirect that to making sure we understand which of the therapeutics really are promising with actual data. picking which of the many vaccine efforts it's worth putting a lot of money behind and building that manufacturing in parallel with the safety and efficacy work, which is very difficult to do. Probably will take about 18 months before we can get to a significant level. So therapeutics could come a lot sooner. Things like manufactured antibodies or using the blood of recovered patients in order to help treat people who are just getting sick. Those, there's enough of them that in aggregate, I'd say it's very likely we'll have those interventions in the 4 to 6 month time frame. But how much that'll cut the death rate in these overloads, is still a bit uncertain. That comes quicker than the large-scale vaccine availability.
You're thinking 18 months, even with all the work that you've already done to this point and the planning that you are taking with lots of different potential vaccinations and building up for that now?
Yeah, so there's an approach called RNA vaccine that people like Moderna, CureVac, and others are using that in 2015 we'd identified that as very promising for pandemics and for other applications as well. And so if everything goes perfectly with the RNA approach, we could actually beat the 18 months. We don't want to create unrealistic expectations. The efficacy of vaccines in older people is always a huge challenge. It turns out the flu vaccine isn't that effective in elderly people. Most of the benefit comes from younger people not spreading it because they're vaccinated, and that benefits on a community basis the elderly. Here, we clearly need a vaccine that works in the upper age range because they're most at risk of that. And doing that so that you amp it up so it works in older people and yet you don't have side effects. If we have 1 in 10,000 side effects, that's way more, 700,000 people who will suffer from that. So really understanding the safety at gigantic scale across all age ranges, pregnant, male, female, undernourished, existing comorbidities, it's very, very hard. And that actual decision of, okay, let's go and give this vaccine to the entire world, governments will have to be involved because there will be some risk and indemnification needed before that can be decided on.
Let me ask you sort of rapid fire, a bunch of questions that we get different answers from depending on every person we ask, but I think you have better sources. What is the mortality rate? What is happening right now? How many people do you think it kills percentage-wise?
Because you don't see all the cases, you get the denominator wrong. It's clearly, 1%, 1.2%. Germany is a great example where they got their testing act together and they have interventions, and they're at about that rate. The China data after the Wuhan overload came in at about that rate. Places like Spain and Italy aren't testing broadly yet. Their testing is even more limited than ours, which is still completely misprioritized. So, it's not much more than 1.2% if you have a fully functioning health system to treat those who get serious respiratory problems.
What about asymptomatic spread? I've read that anywhere from 10 to 25% of the spread could be coming from people who don't show symptoms. What do you think it is?
Yeah, that's we have this Seattle Coronavirus Assessment Network that's really going to understand that. I think it's very unlikely the numbers are anywhere that high. I know there were studies, but the way they were done, chest CT scans are going to show you other diseases. It's very unlikely there's a lot of asymptomatics who never become symptomatic, and yet they're infecting people. And the work, and there's many countries that the foundation has gathered together on this, including the UK and Germany, and we're going to get some other sites in the US on this. We need to know that number because that deeply affects rebounds when opening up. And there is some data that suggests it's not a gigantic number, but very, very important to pin that down.
Serological testing, the idea that you could test and see who's got antibodies in their blood and then maybe say perhaps they have immunity. Does that sound like a good plan or something that we should be working towards?
Well, it's not very interesting because the extreme measures we're taking are to try to make sure that the total infection rate is a small percentage of the population. So the U.S., we should end up with less than 10 million overall infections. So that 10 million out of 330 million is not a meaningful amount of herd immunity. Now, those people, the most interesting thing about those people, maybe they could go do risky jobs, but the thing we're working on, we have 6-company consortium, is to look and see if the blood in 2 different forms from those recovered patients can be used as a prophylaxis or therapeutic in people who are getting sick. And that, that's likely to be fairly promising, although it'll take us a few months to be sure of that. But the serological test is more about understanding the science than it being actionable individually. The PCR test, which is very sensitive, that we need to prioritize, that is the key to tracing contacts and really getting people to go into serious quarantine. Serological only goes positive after you've infected most everyone you're going to infect.
Bill, let me ask you kind of a question, a philosophical one. Just looking at the inequality arguments, things that came out after 2008 and the financial setbacks that we saw then, you kind of wonder what happens now. I'd seen something on Twitter the other day that said we have suddenly gone from unskilled labor to essential workers overnight. How do you think this plays out in that debate, just in terms of inequality, watching white-collar workers who get to stay home versus blue-collar workers who are on the front lines on this?
Well, it's very unfortunate that the job losses are concentrated in the part of the economy with households who don't have high incomes. These service-related jobs are where, we're shut down right now, and those will take time to come back. If you look at a country basis, although the developing countries don't have big numbers yet, because the international travel into those countries isn't as large, over time, the deaths, the overload of the medical system will be far worse in developing countries than it is in developed countries. So the fact that when things are bad, those who are worse off suffer the most, that's dramatically the case here. And so government policies really have to look at that hard in terms of the unemployment insurance, which businesses employ lower income people. Some of these policies, are very broad brushed today and not that targeted. And because we're in uncharted territory, that's okay. But as we tune them, we need more data, and the foundation is doing some work to gather data so that the policies can have a equity element to them.
The foundation has also spent a lot of time working on education and watching kids out of school right now, watching governors in some states already canceling school for the rest of the year, wondering what that means for the fall. I wonder that same question there. There are kids who are able to get online, have school teachers and school systems that are set up online, have adults who are in the household who can help them out and kind of push them on their way. But it seems like that's another big area of inequality. What should we do about that?
Well, it's a big problem because if your school doesn't have that online capability, you've lost 3 months of learning. I do think school will be able to resume in the fall, but I don't think this school year there's going to be any significant attendance. Maybe in the summer people would do something special, but that would be very hard to do. As you say, most of the private schools, they're used to online. They've made sure all their students have the device and the connectivity. Different school districts have decided some don't do online learning because it would be unjust in terms of the kids who don't have access. And so that's really a dilemma. There are philanthropists, Ray Dalio, Jeff Bezos, and many others who are trying to fill that gap, get some devices and connectivity out there. But, in the end, the low-income students will be hurt the most by these school closures.
In terms of being an investor, obviously you're a well-known investor. Not that you're probably spending that much time thinking about that, but have you changed your investment strategy at all since this all took place?
No, I haven't put much thought into that, and I'm able to delegate a lot of that. There are whole industries that are going to have reduced demand even after supply comes back. And, capital spending, cars, houses, all those things, it's hard to think that the general animal spirits will be anywhere near what they were before this got started. But I haven't mapped that into, what it means for the market.
What does your day look like these days?
I'm on a lot of video calls. We're talking about, okay, how do you make 7 billion doses? How do you get these trials? There's over 20 compounds that look promising as therapeutics. Some are highly touted, actually, where the data is not looking that good. Some that aren't, fortunately, not talked about, so we won't have panic buying of those things, are starting to look good. So overall, I'd say that's a hopeful area, for several months ahead. So lots of meetings, political leaders, governors, heads of countries. Cyril Ramaphosa's head of the African Union and South Africa, and talking about how you tailor policies for developing countries. We're just mapping what we're able to do onto those countries is not going to work, and sadly they won't be able to reduce the rate of spread like the rich countries that have taken this seriously.
You mentioned potential therapeutics that are out there and a lot that people don't know about yet, so we're not hoarding them. What do you think about hydroxychloroquine?
We really have to wait for the data to come in. We have seen why it looks good in the test tube and realized what makes it look good in the test tube doesn't map to the human model. That doesn't mean that there's not some possibility there, but it's what's crazy is that people latch on to remedies. We'll have data, and I believe some of them, including using recovered patient blood, antibody manufacturer, a few of the antivirals. Some of them are likely to work.
In terms of testing, you keep saying that that's a really important thing in order for us to kind of get back to business. I know of healthcare workers here in the New York area who have been exposed but can't get tests. They may not have symptoms yet. When do we get to the point where we actually have enough tests that are out there and are able to really track this in a better situation?
Well, the access to the back-end capacity of what's called a PCR machine is completely unmanaged. And so, you can have somebody without symptoms who gets tested every day in some wealthy community, and that definitely is going on. And you can have a healthcare worker, like you say, waiting 3 or 4 days. Anytime the queue is over 24 hours, that's complete mismanagement because the value of the result is far less worthwhile when you're not getting it very, very quickly. The best case is the PCR test goes positive before you're symptomatic or infectious, and then you can act in such a way that you never infect anyone else. The natural thing would be to do like South Korea did and create a unified system. That we haven't gotten any interest from the federal level. So the thinking is to create a website that you go in and enter your situation, and it would give you a priority number. And then hopefully all the people who control the capacity limit the priority level that they accept, so they're giving these very quick results and to the right people. And until we have that, we're in big trouble because as a percentage of 330 million, we're not going to be able to test many people, even with the capacity we'll have with the new machines and the so-called strip test. We won't every week be able to test more than a few percent of the population. And so to see rebound, it's got to be exactly the right few percent.
And Bill, you mentioned that you think we will be going back to school in the fall. Do you think people will be back at stadiums, that they'll be getting on airplanes, maybe going on vacations at that point too?
Well, I need maybe to kick off a discussion about this, what opening up looks like, which is, at the earliest for the U.S., I would say at the end of May. But the discussion of which activities bring societal value and how much risk of rebound they bring, that's something everybody should participate in. And I'm starting to write up my thoughts about that over the next week. I don't think going to big, say, public sports types events, that the economic benefit relative to the risk, that will work out until we're back in normal times. I do think manufacturing, construction, schools, where you adopt protocols that are helpful there. We see most businesses in China opening up. We see places like South Korea, who had a medium-sized epidemic, able to run things. And so really, how do you draw that line for that period that's going to be longer than we want it to be? That eventually the government's going to have to take all the expert input and create a new regime for what's going on that's extremely sensitive to how well it's working through the quick turnaround prioritized testing.
Bill, I want to thank you very much for your time today. We truly appreciate it.
Thank you, Becky.